correction. And the second talk is going to be how we can treat scoliosis through minimally invasive technique. Uh-oh. That's the end, thank you. You know what, I don't know how to fix that. I hope you have any questions?
It was very quick presentation. Thank you, Dr. Fessler.
I'll tell you what, let's do this. You know what? Let me give the other talk first, and then we can recopy this one. Okay, let's do this. Let's go to the other talk.
Thank you.
So the problem we're going to talk about here is that in adult scoliosis, the decision to have surgery is often dictated by pain and disability, not by deformity. In a patient who has reasonable balance and not a whole lot of back pain, radiculopathy is often the primary cause for them to have surgery. And it's often the fractional curve below the major curve that is causing that pain, because it's compressing and exiting nerve roots. So the question is, what can we do to relieve their symptoms in a small operation and not fully correct their scoliosis? So this has been published. This is coming out of a research group I'm part of called the International Spine Study Group. And we've published this data. What we did was we compared open surgery for fractional curve correction to minimally invasive, circumferential minimally invasive surgery. In open surgery, in addition to indirect decompression, laminectomy is often relied upon for decompression of the nerve roots in order to relieve pain. In minimally invasive surgery, however, it has gone away from doing direct decompression in favor of indirect decompression, essentially putting in a cage to decompress the nerve roots. So this study evaluated the outcomes of treating the fractional curve in adult scoliosis with minimally invasive technique versus open technique. It's two retrospective analyses of a open database, which included 11 institutions, and a minimally invasive database, which included 10 institutions. Patients were between 2009 and 2013. They were propensity matched for this analysis. The inclusion criteria was greater than 18 years old, a fractional curve of at least 10 degrees, and at least one of the following: SVS of 5 centimeters, a PT of at least 20 degrees, a Cobb angle of at least 20 degrees, and PI minus LL of at least 10 degrees. So when we look at the preoperative fractional curves between the open and the minimally invasive, They were essentially the same, so there was no significant differences. When we looked at the number of levels fused before propensity matching, in the open group there were many more levels fused than in the minimally invasive group, 12 to 6. So then we propensity matched them and eliminated all those with the high number, so that when the groups we actually compared had an equal number of levels fused. So we're comparing apples to apples. What we found was that both of the techniques, whether it was minimally invasive or open, corrected the fractional curve very effectively. Interestingly enough, minimally invasive actually did it a little bit better than open surgery. In terms of pain reduction for visual analog score of the leg, minimally invasive significantly improved leg pain better than open surgery, and they both decreased back pain. In terms of the amount of posterior or direct decompression, 80% of the open patients had direct decompression. Only 20% of the minimally invasive group had direct decompression. And in terms of interbody grafts, 100% of the minimally invasive group had interbody grafts, whereas only about 30% did, and both of those also reached statistical significance. There was no differences in the Cobb angle correction, PI minus lumbar lordosis, oswestry, or VAS back pain. And in our conclusion was that correction of the fractional curve was similar, whether it was done through minimally invasive or open techniques. We had a significantly lower percentage of direct decompression in the open group due to the higher percentage of the interbody grafts, and correction of leg pain actually was better in the minimally invasive group. I then went back and did another analysis independent of this particular study group, and that is, what are the various techniques we can use to relieve the patient's symptoms but not correct their scoliosis, because in the study I just showed you, we only did fusions. So the indications for treatment was clear radiculopathy, radicular pain much greater than back pain, in some cases poor general health or advanced patient age, or if the patient refuses full correction of scoliosis. The surgical options that we looked at was A-lifts, T-lifts, two-level T-lifts, decompression of stenosis, or foraminotomies. And this was our entire cohort of patients. We had relatively large group of patients. The only significant differences between any of these groups was that the down here, the lumbar lordosis was greater in the T-lift and the two-level T-lift groups than in the decompression or the A-lifts, and because of that, there was a significant difference in PI minus LL between those groups as well. So for example, we have this 34-year-old patient who's got significant scoliosis, but her only complaint is a left L5 radiculopathy. So this patient underwent A-lift. This is, so we had 10 patients altogether. These are the data which we just took a quick peek at. Initially in this patient group, A-lift significantly decreased back pain, but by 6 months it had jumped back up and very slowly came down again by 2 years to get pretty good back pain. The patient I just saw you actually did not do great with this. She still has horrible back and leg pain, and she now is scheduled for a complete correction of her scoliosis. In terms of leg pain, we really didn't get a very good result with A-lifts at all. A slight improvement initially, but then it even got worse, and it's kind of leveled off to be about the same in this group. We had no difference, maybe a slight increase in mental health on the SF-12, but the rest of them SF physical, SRS 30 scores, VR-12, which is essentially the same thing as an SF-12, again slightly increased over time, and not much difference in the physical or the VR-6D. How about the second group, our T-lifts? We had 25 patients who underwent T-lift operation. This is, for example, this patient has scoliosis. She is status post in L4-5 fusion, and she's got bilateral lower extremity pain. This is her MRI showing severe disease, collapse at 4-5, horrible facets at that level, and she underwent a single level T-lift. So T-lift in this group of 25 patients had dramatic and immediate reduction in their back pain, which remained very good throughout 2 years. Same for leg pain, excellent relief of leg pain, stayed very stable over at least up to 2 years. Not much difference in mental health scores, physical ability scores. SRS 30 improved a little bit, but then started coming back down. VR 60, again, no significant changes. And then we have our 2-level T-lift. There were only 5 patients in this particular group. This is an example. This patient had a 2-level laminectomy and now has iatrogenic instability and scoliosis. She underwent lateral interbody fusions with posterior instrumentation for 2-level. And again, in this group, we had excellent relief of leg pain, which continued to improve over time up to 2 years. Improvement in mental health scores as a result of that. Her back pain also improved. I lost that slide, but her back pain also improved. Physical functioning improved. SRS 30 scores improved significantly. Mental health scores improved significantly. Physical functioning scores and the VR60 scores all kept improving. Now, how about decompression of stenosis? It's really nice to be able to do a really little operation on these patients, especially the ones that are sick, and an 85-year-old patient with multiple comorbidities, including cardiac and pulmonary emboli and things like that. Those are the patients we chose to do just decompression of stenosis. For example, in a patient like this with significant scoliosis, horrible sagittal deformity, she refused correction of that sagittal deformity, but had significant stenosis, so we just did a decompression on stenosis on her. Initially, we had a pretty good result in back pain, but by 2 years that had returned to the level. Same thing with leg pain, improved for a little while, but by 2 years was at least as bad as it was preoperatively. No change in physical health, mental health, VR12 mental health, VR12 physical health, VR60, none of those improved. Well, if that one didn't do so good, how about a foraminotomy? These same kind of patients, what about just doing a single or a 2-level foraminotomy, like this patient who has pretty bad scoliosis, bad fractional curve down below, significant compression of his foramen ideally. Well, this would be a great patient to do a foraminotomy on, and that's what we did. We did a 2-level foraminotomy on this patient. What I do when I'm doing foraminotomies in these individuals, I always put in this unilateral instrumentation. It keeps it from collapsing down, because as soon as I do a foraminotomy on the concave side of the scoliosis, they collapse right down and pinch the nerve again. So I'm not actually doing a fusion here. I'm just using it to keep the foramen open. I've had really good results with that. And in fact, foraminotomy looked really good. They came down, jumped up a little bit, but then came back down, and by 2 years had stayed really good. Same thing for back pain. Gradually came down, excellent results by 2 years. Mental health didn't change very much. Physical health didn't change very much. SRX 30, though, improved slowly over time. Mental health on VR12, not much change, and not much change in VR physical or the VR6D. So my conclusions from these: some individuals with smaller operations, in some individuals, smaller operations might provide sufficient relief of symptoms, even in the context of scoliosis. Our preliminary data suggests that limited fusions and minimally invasive foraminotomies may be effective at least up to 2 years. ALIF seemed to decrease back pain but provided no benefit to leg pain, and minimally invasive decompression was a complete failure. Thank you.
Thank you, Dr. Fessler, for very good, nice presentations. Have any questions or comments? Yes.